Okay, we've been sent a good case here. Several things going on, several questions presented, and several questions that I have on this particular case. Excuse me. So, what I'd like to do is begin with the lower right-hand side. It looks to be have a root left there that needs to come out, obviously, as we can see in this image right here. And the bigger question is, this is probably a premolar root, it looks like, and then missing tooth here, some tilting of this tooth, maybe a crown that was here at one time, maybe a bridge from here to here that has broken off and come off. So we have several things going on that we need to address. So the big question, and here's the plan that was sent to us. It's a Strawman tissue level implant. I don't have a lot of experience personally with this particular implant. It's a wonderful implant. I just don't know much about it. But the big question here is, are we going to replace this site with one implant, two implants, and how does that affect our plan? And the first thing I think about in looking at this particular implant plan that's been presented to us as it is I look at what the restorative contour is going to be. And here we can see, here's the outline of the molar right there. Here's the existing premolar from the bridge, it looks like, and another existing premolar from the bridge right here. And if we look at these contours based on this particular implant, that's kind of what our final crown will look like. So my question is that an adequate type of implant for this particular situation because of what may come as a food trap in here and in here? So is there enough restorative position, in other words, to be able to place this implant at this particular position? Number one. And then the second question is since the bridge had two premolars, are we better off with one implant here and one implant there instead of one single implant? So these are questions that only the clinician doing the case can answer, but these are the things I want to bring up. So for me, I'm going to plan this case as if I were in my office, and that is, and looking at this, I see one premolar, two premolars. So I would plan this as two implants. So what I'm going to do is instead of planning this as a single implant, I'm going to plan it as two implants. Now the question is going to come is what if my patient can't afford it and all of those things, and uh, you know everybody has a different philosophy. My philosophy is work something out with the patient. Let's do ideal treatment so that we don't have to deal with this down the road, so that we're not left holding the bag because of the patient's issues. So I always believe in trying to do the best thing, the right thing for the patient, and letting the patient make a choice. And as long as that choice fits in within my ethical areas, then I'm fine. So let's begin by evaluating this particular plan. So, the first thing I'm noticing here is when I look at this, and let's kind of use our drawing tools here for a second, and let's go ahead and draw the outline of our bone. So we'll probably say actually, I'm going to go, let me redo that. Let's go with the outline of our bone, and I'm going to say our bone is actually probably be about right here. And there's the outline on this end and the outline on that end, and obviously I've off a little bit there, but that's okay. So the first thing I'm noticing is we have more space here than we do here. But more importantly, what I'm noticing on this particular situation is that this implant, the threads are in very close to, if not into, the cortical plate. And my preference is not to totally engage the cortical plate on both sides. My preference is to have the implant a little bit more centered. So in a case like this, my preference would be to have the implant centered like so. And then to get the head back in the restorative position, we may just use the tilt feature. So now in doing this, we've got our implant more engaged in this and not so thinning out the cortical plate. And again, every implant makes a difference, as you can see on the Strawman bone level implant, sorry, tissue level implant. There are not very aggressive threads, so our osteotomy is actually going to be this size right here. Sorry, not there. right this size right here, just to the inside of the threads, if not a little bit more. And then all we have engaging the thread is these little pieces right here. So we're going to have to remove all that. So if I had the implant over against the cortical plate, I'm not a big fan of that. The next thing we have to think of is, from the bone level perspective, is here's where our bone level is. Okay, now where's it going to be from the extraction? The general rule is about 1 millimeter lower. So in this particular case, what I would do is anticipate the bone level coming to about right here. So I would plan my implant based on that, if not a little bit deeper, and maybe in this case even deeper than that, to accommodate for the restorative height that we need to get a good restoration with good emergence. So those are the things we have to keep in consideration. And one last thing is, I know that there was some question about the nerve position, and looking at this, my guess would be that the nerve is right here, not where it is drawn, and I would err on the side of using this as my nerve position. Just I don't want to be too close to the nerve, so I would say that this implant as it is probably a little too long for my comfort, because I would like to see it a little bit more distance from the nerve. So that's what I'm seeing here. Mesiodistally, everything looks good. The occlusal plane looks good. The occlusal table, generally speaking, look good. We're coming right in between the teeth. Again, that presents an issue of, contours. Are we going to be able to create these contours with the abutment there? I'm just not a big fan of putting a single implant here. So what I would like to do is simply plan this for multiple implants. So I'm going to go ahead and delete this, and what we'll do is we'll plan the site, and I happen to like using the Nobel implant, so that's what I'll plan it for. And I'm going to start with my ideal for a premolar, which is 4x13. I'm going to drop it in place here, and then I'm going to adjust it. And one of the things I like to teach people is, oftentimes we can use the opposing adjacent root as a guide. So now we've got that implant pretty straight, and then I'll just go ahead and drop it right over here. And this is often, not always, a good sense of the angle at which the implant needs to be. And then obviously we need to get it in to the buccal lingual dimension, just like so. And here what we can see now is now we're going to start engaging a lot of fresh bone, so I'm not so worried about the stability. Obviously the length needs to drop down to probably 11.5, if not 10 millimeters on this case, just because I want to avoid any chance of creating issues with the nerve. And then we'll look at this from occlusally, and we can see that we're still a little bit to the distal. So to correct that, I'm going to tilt. Okay, and now we're starting to look pretty darn good here, and tilt a little bit lingually to get into the central groove of that tooth, like so. And now I'm starting to have a much better look here. And again, looking at this, my only other concern here is where's my bone level. We may need to drop this implant a little bit more and anticipate a little bit more bone loss because of this buccal bone position right here. So that's my first step. Now I will go ahead and drop in another implant at site number 29, make it parallel to 28, use the same size implant, use our box here to make sure that we are at least 2.5 millimeters away from the adjacent implant, and there we go. So that would be my suggestion in this particular plan, is to, instead of using a single implant, to go for a multiple implants to replace it with 2 premolars. And then the other question about the nerve, the good news on this is if we use this view right here, we can, again, it's never 100% accurate, but we can assume that that's the apex of this tooth, that's the apex of this tooth, the apex of this tooth. So we can assume that it's very unlikely the nerve goes above that. So I would use this as my guidance line for determining where my nerve, worst case scenario, would be. Again, I think the nerve is down here based on this x-ray here, this view of this x-ray here. I say the nerve's here, but I'm going to go on the assumption that it's right here, and here we can see that we've got the space and the room to accommodate for this. So hopefully this has been helpful and educational. If there are any other questions, uh, hopefully we can give you some insight. And one last thing we can check is we can use this view again here, and we can check and see, look, these implants are going to come out of the center of those teeth. They're going to be very well done, and they're going to give us a good restorative position. So thank you very much, and look forward to additional cases.